Well, we're back just like we threatened to be. And, usually during the break, I think about what I talked about in the first half and I get certain feelings. And very often, when I get those feelings, I start wondering about things. So, first of all, the one thing I don't wonder about, the one thing that I know for sure is I threw a lot of intense material at you, perhaps a lot more than you ever need to know to practice medicine, okay? Uh, but I don't always know if most of you were overwhelmed or if you were bored, because you already knew that it was common knowledge, in which case you probably wouldn't even be here. So there's a certain couple of questions I have to ask you right now, okay? And here, I'll drag it off so your responses don't get recorded. Oh, hold on. Let's see if we could see some of your answers better, okay? Um, I'm going to ask you a question. I knew that the stuff I threw at you was intense in the first hour, and I can also tell you the second half hour will be very, very fun and visual and not quite so intense. So I have to ask you the material that we saw in the first half, what percentage of it did you already know? Because there's a certain percentage that I shoot for. And if you give me a certain percentage, I'll be happy. But I want to see some of your responses, okay? And I know some of you might not. And I'm seeing 10, I'm seeing 70. Please answer if you can. I'm seeing 60. Well, okay, I got a general feel. Okay, I'm seeing 30. What I'm seeing is something that averages out to about 50, okay? And that's what I shoot for, because I think a lot of what I teach should be repetitive, but some of it should be new. And if it's like all new, then I shouldn't even be here. But if you could say, I've heard a lot about that, maybe about half or so, then I'm very, very happy. Okay, the other thing I could tell you, let's see, is that the rest of the session, which will be the second half now, will be fun, easy, visual, graphic, and not quite so intense as what I did before. I don't have to ask you if the first half was intense, because I know it was intense. It was intense for me, too. So let's finish up on some of our PowerPoints here. We're way more than 50% done, maybe 70%, I don't know. And what happens when acute inflammation is over? The battle is finished. All you got is dead bodies on the battlefield. Maybe they've been cleaned up. Well, in many cases, hopefully most cases, there's 100% complete resolution and the normal regenerative processes, which we're going to be talking about in the next webinar, by the way, turn the tissue back into complete normal appearance. Like, the most horrible, destructive looking pneumonia can, if treated properly, can look like absolutely perfectly normal lung after weeks, maybe months after good treatment. Depending on how much destruction there have been in the process relates to the amount of scar. So the amount of tissue, especially the intercellular matrix, intracellular matrix, determines the amount of scarring as well. And also another thing to remember is that even though the acute phase is over, there still may be a persistent chronic inflammation. So now you're looking at tissue, and it's no longer infiltrated by polys, but it may be infiltrated by monos, which are the hallmark of chronic inflammation. Okay, what does acute inflammation look like? Well, we've already told you 10 times what it looks like under the microscope usually, bunch of neutrophils. But what does it look like in real life, clinically, surgically, the patient? Well, there's one example of a type of acute inflammation where the prominent feature is fluid, okay? And this produces a blister. You might call this serous inflammation. Sometimes serous inflammation is associated with acute inflammation, and sometimes chronic, like a serous middle ear infection is generally regarded as chronic, and that could be primarily something that is filled with sort of a watery, transudative type fluid without much protein in it. It could be fibrinous. You know that fibrin is one of the end products of both coagulation and very much tied in with acute inflammation. So fibrin can look very red or it can look yellowish. On microscopy, not only is it pink, like just about everything else in the world might look pink, but it will be darker pink, more eosinophilic than the other tissue. That's why we have introduced this term fibrinoid necrosis, which we talked about the other day. But still, if you think of having a lot of neutrophils as being the primary cell of infiltration, what if those neutrophils just formed a big pocket of neutrophils, which we call an abscess or a pocket of pus, or perhaps so many neutrophils that's actually draining? This would be called a purulent feature of acute inflammation. So what is an abscess? It could best be defined as a pocket of pus. Now there's probably a few other things in there like fibrin, but for the most part, when you see something in the microscope and it's wall-to-wall neutrophils, you can believe you're probably in the middle of some type of abscess, like this over here. And this is a good example of what I said before. You may say, well, look, a lot of these cells basically look round, but yeah, some of them look kind of multilobulated. And you might look at this, and if I said to you, well, count the number of monos and count the number of polys, I bet you a lot of you would come up with a high percentage for monos. But remember, some of these monos are actually two lobes of the same cell as well. So I can reassure you that almost 100% of the cells in the middle of this abscess or fibrinopurulent exudate are neutrophils. Now, what about the non-cellular stuff? What about this pinkish stuff? That's probably fibrin, okay? So fibrin and neutrophils equals pus, equals abscess. Sometimes you'll hear the word ulcerative inflammation, like ulcerative colitis. This is a colon, this is a large bowel, and you can see that white line is the muscularis, and there's the fat, around the connective tissue, around the serosa, or around the adventitia. And then you see the mucosa is very, very hemorrhagic. Why is it hemorrhagic? Because it's ulcerated. Now, does that mean that the ulcer causes the inflammation? Or does the inflammation cause the ulcer? Well, it's actually both. Because once you have that protective layer of epithelial cells in your GI tract, you are now letting in potentially hazardous, damaging bacteria causing inflammation. On the other hand, if this inflammatory reaction, which you see primarily here in the mucosa and submucosa, was destructive enough, it could produce the ulceration. So basically, when you say what came first, the chicken or the egg, in this case, they both came first, okay? I'm showing you this again, not as a new thing, but as kind of a review of everything that we talked about. You have normal tissue, normal function, normal histology, followed by vasodilatation, increased permeability of those dilated vessels, leakage of fluid from the vessel, leakage or transmigration or diapedesis of white cells, particularly neutrophils, which at first marginate, roll, and adhere. They are then attracted to the area that's causing the inflammation, be they bacteria or dead tissue, by a process called chemotaxis. We then have activation of those neutrophils, the lysis of the lysosomes, phagocytosis in many cases of the particles, the dead cells, the bacteria, maybe the viruses that are the cause of the acute inflammation, and then determination of the event, resulting in complete resolution of normal tissue, scar, or chronic inflammation. And sometimes a scar can follow the chronic inflammation. It doesn't necessarily follow directly acute inflammation. Let's talk about chronic inflammation now. I think a much simpler topic. Just as though polys were the primary cell of acute inflammation, monos, in other words, not monocytes, but mononucleated cells, not polynucleated cells, like lymphocytes and macrophages. The pathologists frequently call macrophages histiocytes, but probably for consistency, it's best to just call them macrophages. Okay, they have little granules too. There's a perfectly globular or spherical type of nucleus. It might look spherical as a histiocyte or a macrophage too, but if you look closely or go on an electron microscope, you can see it's not really perfectly round, but it basically has a one ball configuration, which is, we call that a mono as well. And remember, you can also have a monocyte, which is a macrophage that hasn't gone out of the blood yet. So when a monocyte migrates into tissue, it has a name change operation. It's then called a macrophage. Same cell line. What causes chronic inflammation? Well, it could be the persistence of the infection. Perhaps that persistence is factored by a prolonged exposure to the insult. Perhaps all of the dead tissue or injured tissue or microbes have not been completely cleared out. Another, probably a very, very, very big cause of a chronic inflammatory infiltrate is autoimmunity. When your body attacks its own cells in a whole large variety of systemic and localized diseases, usually the inflammatory result is a mononuclear or chronic inflammatory exudate. So we already know that lymphocytes and macrophages are the monos. Okay, these are the main cellular players of chronic inflammation. We also know that macrophages could be called histiocytes. We know that plasma cells basically are modified lymphocytes, so you could add those as well. And to be honest and fair, you might even also give an honorable mention to the eosinophils and mast cells. And that could be seen in a chronic inflammatory, cell infiltrate as well, especially if the cause in the case of the eosinophil has been a parasite or an allergy. Okay? So, just like acute inflammation are acute inflammatory cells, perhaps causing tissue destruction, perhaps followed by healing. The same thing with chronic inflammation. Now, chronic inflammation could completely heal up, just like acute inflammation did, but depending on how much of the substance, the tissue was destroyed, could very easily result in a scar also, okay? There's a very weird type of chronic inflammation in which the chief inflammatory cell is a macrophage, and they're localized collections of macrophages. And they're called granulomas. And they could be necrotic in the middle. In fact, some of the macrophages could even join forces. Some of the cells can form multinucleated, which are basically fused macrophages, and they could be parts of the inflammatory process as well. Sometimes at the periphery of this granuloma, you could even see little dotted round tiny peppered cells, which you might recognize instantly as lymphocytes. And depending on the age of this granuloma, some of them could last for years or even a lifetime. You might see fibrous tissue or fibroblasts towards the periphery, which you don't see here, I don't think, too much, but they could then involve the entire granuloma, or the entire granuloma could even be calcified, not just fibrotic. But in this special type of chronic inflammatory process, which is a localized macrophage collection, uh, we have four basic things which they're highly associated with. One of them is tuberculosis and other mycobacterial infections. One of them is sarcoid. Many of the fungal diseases, both the superficial skin fungal diseases as well as the deep systemic fungal diseases like histoplasmosis, blastomycosis, coccidiomycosis, these also generally form granulomatous patterns of inflammation in foreign bodies. You may have heard of the term from the surgeons called stitch granulomas. In other words, if you put in suture material, which doesn't normally disappear by itself, they are basically attacked by these collections of macrophages, some of which are giant cells called also have a granulomatous response. Another thing to remember clinically is that any granuloma can become necrotic, okay? However, from the point of view of differentiating tuberculosis from other granulomatous diseases, the granulomas of tuberculosis, not just the big granulomas, but even the tiny microscopic ones, are more likely to show necrosis or a caseating type of necrosis in the middle of the granuloma, whereas other granulomas could also become necrotic. But if they are non-caseating, that often differentiates whether the granulomas you're dealing with are tuberculosis or other infections or other granulomatous diseases like sarcoid, for example. So that's one thing that you might keep in mind. And I know what you're thinking. You're thinking, hell, wait a minute. How could you call it caseating if it's microscopic? When you don't cut cheese with a microtome, you cut it with a knife. Well, even though caseation is a gross term, meaning it's crumbling, sometimes they apply it and often apply it to the microscopic level as well. Okay, well, what happens when an infection spreads? Well, guess what? It's the same roads that tumor takes when it spreads. An infection will at first seek to travel through the lymphatics into the lymph nodes, for these cells perhaps to be processed antigenically and produce cells which will create ultimately reactions or antibodies against this. And it could make a lymph node very, very large. And if you have a lymph node that is large acutely, okay, that's mostly like due to inflammatory cells enlarging the lymph node. And that could be painful. Whereas a tumor that involves an enlarged lymph node is not likely to be painful. That's another little trick, another little buzzword that you'll see on exams. If they say a lymph node is painful, you're probably talking about an inflammatory process. If they say it's non-painful, then you're probably got to be more concerned that maybe it's a neoplasm. Okay, we're down to our last two items here. Systemic manifestations. Well, you know, people with acute inflammation, they can have fever, they can have chills, they can have elevation of a acute phase reactant or something in this alpha-1, alpha-2 region called C-reactive protein. But there are a wide variety of other proteins, and we talked about them in the acute inflammatory response that can be found in the alpha-1 and the alpha-2 phases of a serum protein electrophoresis. And these are called acute phase reactants. These are the things that cause that second and third finger to be bigger. Many of the complement proteins are in the alpha-1, alpha-2 region. Many of the coagulation proteins, the big one like fibrinogen. Some of the protease inhibitors are in it, okay? Some of the metal binding proteins. But if you notice that the alpha-1 and alpha-2 region are increased significantly. They are no longer the smallest of the two fingers, but maybe they're as big as some of the other ones. then you could say they're probably increased because of the many of the chemical mediators we talked about. Now, what happens when there are increased amount of these proteins in your serum? Well, maybe your red cells do not settle as fast as they should because of the increased number of acute phase reactants. And therefore, the erythrocyte sedimentation rate, or the rate at which blood cells settle, could be increased. That's another lab test that's done, and it's easy. And there's two different kinds. There's the Wintrobe and the Westergren, and I don't know, usually one is considered better than the other, but they're still fighting as to which one is best. Of course, if there are increased neutrophils in an acute inflammatory process, they're probably also in the blood too. And not only are they increased in the blood, but because they're being increased demand for them, some of the earlier cells like bands or even metamyelocytes could be increased in the blood too, which are normally not very common in the blood. In the body's reaction to fight it, you all know that associated with fever and chills, you're going to have increased pulse, increased cardiac output, increased blood pressure. And then you're going to have all of the effects of the various cytokines, which we talked about systemically. Here's a serum protein electrophoresis. I should have showed it to you already. But let's say this was a hand. Well, we all know that your thumb is the biggest finger, so we'll call albumin the thumb. And there's your other four fingers. Now, normally, your second and your third finger are the smallest. But in fact, sometimes they're barely recognizable as blips. And of course, it's this big stretch of gamma globulins or beta times, which are the second and third biggest fingers. But sometimes this alpha 1 and alpha 2 can be equal to them in size or perhaps even bigger. Now, as a final thing, I promise you I wouldn't throw more intense stuff at you. But if you really want to know the major acute phase reactants, if you want to memorize all these things, most of which we talked about in the discussion on chemical mediators, but I think it'd be better to just lump them into complement proteins, coagulation products, protease inhibitors, things that bind metals, and a few other proteins. And most of these play a role in the chemical mediator process of the acute inflammatory reaction. We're done. And I feel like we did a good job. And you know I'm going to play another Bob Dylan song at the end. And thanks for coming again. And sometimes I think at the end of a webinar, I should probably listen to some of the questions you wrote, or perhaps take more. But sometimes I'm tired myself. So let me just answer some of them quickly. Somebody said, what does AKA mean? Well, that's just an acronym that means also known as. Is fibrosis characterized by fibrin? The answer is no. Fibrosis is characterized by collagen. Somebody said, what is the difference between a monocyte and a generic mononucleated cell? Well, a monocyte is a macrophage line that is still circulating within the blood. So are all monocytes mononucleated cells? Yes, but not all mononucleated cells are monocytes or macrophages. Some of them could be lymphocytes. It's a generic term generally referring to the character of the nucleus. Okay, and I see a lot of you answered my original questions nicely. And there's a few more questions which I'm going to skip because I'm tired. But thanks for coming. Our next webinar will be in 2 days, which is 46 hours from now. And we'll talk about a topic which is very, very closely related to the inflammatory process, and that will be the healing and regeneration process. And this is not going to be very clinical. A lot of it is based on, pure research, why and how do cells regenerate? What is the healing process? Stuff like that. So let's call it a day. And